Good evening, all. Welcome all to the Vijaya Diagnostic Center webinar series. We are regularly conducting these webinars every 15 days, almost every fortnight. And today we have with us Dr. Mansoor and Dr. Rukmini. Today the topic is molecular imaging in neurodegenerative disorders. That is a very, very important topic in neurology. For this, we have chief guest Dr. Rukmini Mridula. Dr. Rukmini is a senior consultant neurologist and director, Parkinson's Disease and Movement Disorders Research Center at Citi Neuro Center, Hyderabad. And she was a former additional professor of neurology at NIMS Institute of Medical Sciences, Hyderabad. And her main areas of interest is again the movement disorders, that is today's topic, and of course cognition also. She has multiple publications of more than 115 publications in national and international journals and 20 chapters in textbooks. And she's founder member and EC member of Movement Disorder Society of India, and of course Parkinson's Research Alliance and of India, and treasurer for Parkinson's Society of Hyderabad, and member of membership committee and MDS, AOS, Reserved Areas, and IPMD, member of newsletter committees and IAPRD. With this small introduction, I welcome Dr. Rukmini to this webinar series. Yeah.
Thank you, sir. Actually, at the outset, I'd like to thank Dr. P. Krishna Mohan, sir, and Dr. Mohammed Mansoor Mohiuddin, as well as the Vijaya Diagnostic Center for allowing me to be in this particular webinar. It's very interesting and very important as a clinician, because I see a lot of patients with movement disorders, which means a lot of neurodegenerative disorders like Parkinson's disease or Parkinson plus syndromes, and cognitive neurology, where you have Alzheimer's dementia or frontotemporal dementia, various types of dementias which we have. And for us, sometimes the clinical pattern can be a little, they can be blurred in the initial period, and it's important to diagnose the patients properly. Basic modalities to diagnosis, but also to prognosticate the patient. And the treatments changes based on the imaging that we get and the clues that we get from the imaging for the diagnosis. So thank you, sir, once again for having me here.
Yeah, thank you, Rukmini, for the inputs. Next, we have the subject speaker to today's evening, Dr. Mohammed Mansoor Mohiuddin. Dr. Mansoor is a senior consultant and nuclear medicine physician at Vijaya Diagnostic Center, Himayatnagar. And yes, the overall 13 years of experience in nuclear medicine, and he received Professor Arcad Gajra's Best Paper Award in conference, and is contributing author in many of the journals. He is very senior nuclear medicine doctor in Vijaya Diagnostic Center, and I have seen him passionate about the movement disorder work related to neurodegeneration, and we published one poster at ECR, also European Congress of Radiology, last year. Welcome you, Dr. Mansoor, for today's webinar.
So, thank you, sir. Good evening, everyone. Let us begin today's webinar, which is titled Molecular Imaging in Neurodegenerative Conditions. So we'll just touch up briefly on the various conditions and what are the imaging findings. So a brief introduction about neurodegenerative disorders. A wide range of conditions that result from progressive damage to cells and nervous system, connections that are essential for mobility, coordination, strength, sensation, memory, and cognition. Diseases involve the gradual or complete loss of structure and function of the neurons. It is increasing in incidence because of increasing life expectancy, and this is a considerable impact on worldwide health. The major risk factors will be age, genetic predisposition, and other factors like gender, low educational status, endocrine disorders, oxidative stress, inflammation, stroke, hypertension, diabetes, smoking, head trauma, depression, infections, and so on. And then there are environmental factors also that play a role. And due to the physical, cognitive, and psychological limitation, these patients need substantial social and financial support. So the proper diagnosis is crucial to aid with prognostication and pharmacological management of patients with neurodegenerative disorders. Imaging helps in increasing diagnostic confidence. There comes the role of imaging, and PET-CT is a part of imaging that plays a crucial role. So let us begin with case 1. This is a 51 years female with right upper and lower limb weakness and spasticity. Past history of surgery for glioblastoma multiforme in the left parietal lobe, and F-DOPA scan was advised to rule out dopaminergic insufficiency. And this is the F-DOPA scan and the corresponding CT slice. And we can see that the uptake in F-DOPA in the basal ganglia is normal, and we are seeing equal uptake in the caudate nucleus as well as the putaminal uptake. So whenever we see a normal F-DOPA scan, it basically rules out Parkinson's disease. So beginning with a normal scan first. This is a 68 years male with history of resting tremors, rigidity, and bradykinesia. And F-DOPA scan was requested for. And here we see that the uptake in the basal ganglia is reduced compared to the previous scan, and the severity is more in the putamen compared to the caudate. The uptake can be a little bit asymmetrical. So this is in favor of Parkinson's disease. This is a very easy scan to differentiate these conditions, and basically to rule out Parkinson's disease and differentiate it from essential tremor. We get a normal scan in essential tremors. And another case, 43 years male with tremors, loss of balance, and bradykinesia. And we are seeing decreased uptake more on the left side compared to the right side, with a caudorostral gradient in the putamen, and caudate also shows little decrease in F-DOPA uptake. So this is a early onset Parkinson's disease. So Parkinson's disease is characterized by deficiency of dopaminergic neurons in the substantia nigra, with the deposition of alpha-synuclein, Lewy body formation, and usually seen in patients more than 50 years. In less than 50 years age group, it's called early onset Parkinson's disease. In 18 to 30 years, it is juvenile onset, and patients respond to levodopa therapy. Now, problem comes when patients don't respond to levodopa therapy. Then we have to look out for atypical Parkinson's disease or Parkinson plus syndromes. So let us look at those examples. This is a 72 years male presented with behavioral changes, memory loss, cognitive impairment, and walking difficulty. So here, this is an FDG PET scan of the brain and corresponding CT slices. Here we can see that the FDG distribution is decreased in areas which is quite asymmetrical. We can see that the left side of the cortex is also the left ganglia, the thalamus, is showing decreased metabolism compared to the right side, and we can see that there is a cross cerebellar diaschisis. So this, but the atrophy, if you see on the CT scan, is quite symmetrical. We don't see such drastic asymmetry. So this goes in favor of corticobasal ganglionic degeneration. It is very simple on FDG PET to differentiate this condition. And the next scan is 65 years male presented with progressive dysarthria and ataxia, and the FDG scan shows significant hypometabolism in the cerebellum. So cerebellar hypometabolism is associated with multiple system atrophy of cerebellar type, and this is a very classical scan to suggest MSA. And another patient, 58 years male, presented with abnormal gait, slurred speech, rigidity, and behavioral changes. And here we have a F-DOPA scan as well as FDG scan. This is the F-DOPA scan, and these three slices are the FDG PET of the brain. And here we are seeing that the F-DOPA uptake in the basal ganglia is preserved. We can say that the uptake in caudate nuclei is decreased compared to the putamen, so it's not completely normal scan. We should see more uptake in the caudate nuclei. And on the FDG scan, we are seeing hypometabolism in the anteromedial frontal cortex here, and that is also seen on the sagittal slice here. And and also we can see that there is hypometabolism in the brainstem. So these features are in favor of progressive supranuclear palsy. Patients also have upward gaze palsy, and FDG PET helps in differentiating this condition, and you can see that the uptake in FDG uptake in cerebellum is preserved, as in the previous scan it was decreased in multisystem atrophy. So this is a case of PSP. And the differential diagnosis of Parkinsonian syndromes from Parkinson's disease and from each other may be difficult in early stages especially, and there is where FDG helps in differentiating these conditions. Now this is an interesting case where a patient presented with hallucination, memory loss, resting tremors, bradykinesia, rigidity, and we have F-DOPA scan and FDG scan, and F-DOPA scan shows decreased uptake in the basal ganglia, especially the putamen, and here we can see it is asymmetric, and here we can see the uptake is it's more severely affecting the right side, and caudate nucleus is also showing decreased F-DOPA uptake, and the FDG scan shows hypometabolism in frontal and parietal and temporal lobes, and we can see that there is hypometabolism in the posterior cingulate gyrus, which actually should be hot. Usually it shows a high grade of FDG uptake like the visual cortex, but here it is decreased. So this is a case of associated Parkinson disease associated with Alzheimer's dementia. So both are neurodegenerative, most common causes of neurodegenerative disorder. We can see them in patients, in a patient at the same time. And this is a case of 82 years male, and this is taken from a journal, presented with progressively developed gait disturbance and choreatic movements for 6 months. So the MRI shows there is diffuse atrophy and hypointensity in the striatum, and there is severely decreased FDG uptake in the basal ganglia. So this was in favor of Huntington's disease, and which was confirmed by CCA. So this is a classic image of Huntington's disease, and yeah, the next case is a 72 years male with fluctuating cognitive impairment, memory disturbance, confusion, motor rigidity, occasional visual hallucination, and we can see that there is hypometabolism in the occipital cortex with sparing of the posterior cingulate gyrus. This is called as the cingulate island sign, and this distribution of FDG is in favor of Lewy body dementia, and we can see that this is a dopamine transport DAT scan, this dopamine transporter, which is done with 123 iodine labeled ioflupine. This is iodine 123 is not available in India. We use F-DOPA scan instead of DAT scan, which are quite similar, and here the uptake in the basal ganglia is significantly decreased. So this findings are confirmatory for Lewy body dementia. So FDG PET plays a role in differentiating different types of dementias. The Alzheimer's dementia, basically, it predominantly affects the posterior parietal cortex, and with sparing of sensory, motor, and visual cortex. It affects parietal and temporal lobes more compared to the other areas of the brain. Whereas in frontotemporal dementia, we see that the uptake in frontal lobes is the metabolism in frontal lobes is significantly affected. And this is an example of Lewy body dementia, where the uptake in the posterior, in the visual cortex is affected with the sparing of the posterior cingulate gyrus, as we have seen in the previous example, the cingulate sign. So this is a scan of two patients that amyloid imaging. So amyloid imaging was initially done with the Pittsburgh compound, which was labeled 2C11, and then we have fluoride labeled compounds, which are fluorobutapir, flutamidamol, but these are not available in India in picking up amyloid plaques inside the cortex. So the FDG PET shows decreased metabolism in the parietal cortex, and also involving the posterior cingulate gyrus, and the uptake, the amyloid uptake is more in this patient, whereas in the healthy patient here, we can see that the amyloid uptake is decreased. Like this is the normal one. We should not see higher uptake of it in the brain, and even the metabolism is normal. You can see normal uptake in the posterior cingulate gyrus compared to this scan. So these are two similar aged individuals. One is healthy and the other has dementia, and these are how the scans look like. So I just kept two scans, the normal and abnormal, for comparison. And Alzheimer's disease is associated with amyloid plaque deposition and tau protein phosphorylation and deficiency of choline neurotransmission in the brain. And these are the various stages. So the summary of illustration findings, this is a chart that I used to use a lot when I had less experience, and it is a good illustrative example and comparison of various conditions like Parkinson's disease, MSA, PSP, CBD, and Huntington's disease, and it gives a good picture where how a presynaptic imaging and postsynaptic imaging and FDG imaging in all these conditions look like. So to summarize, molecular imaging with PET helps in diagnosis of movement disorders, and neurotransmission of dopaminergic system can be imaged by the F-DOPA scan, and local changes in brain metabolism accompanying changes in neuronal activity in movement disorders can be imaged by FDG scan, and FDG scan also plays an important role in dementia by assessing the cortical hypometabolism pattern in these diseases. Thank you.
Yeah, thank you, Dr. Khan, for a brief and excellent presentation, overview of dementia and movement disorders related to nuclear medicine, PET and SPECT imaging, molecular imaging. So, so Dr. Rukmini, what are your comments on this? Like, how when you want to have this, molecular imaging in your protocol after MRI and other things?
Thank you. Actually, it was very nice presentation. It's a very nice overview and gives the entire gist of what we look for in patients with movement disorders. So there are a lot of scenarios in the clinical practice where we are not able to make a clinical diagnosis. Even with imaging, it wouldn't help. Especially for patients with Parkinson's disease, as you had specifically told, essential tremor with Parkinson's disease, sometimes it's a little difficult to differentiate between the two groups. So then definitely the use of F-DOPA PET comes in. Sometimes you have patients who have on psychiatric medications or antacids like levosulfuride, where they can also induce Parkinsonism. So when you have a drug-induced Parkinsonism, we don't know whether the patient is going to develop Parkinson's disease or it's just a brief drug-induced Parkinsonism. So definitely the role of F-DOPA PET comes into play so that you know whether to treat them or not. FDG, FDG PET is definitely to differentiate between the Parkinson's disease and Parkinson plus syndrome, especially for PSP, MSA, DLB. It is a very good option. Sometimes early stages, so there are some entities like PSP, where you can't differentiate between the two of them. So both of them respond well, they don't have falls. Clinically, they look like Parkinson's disease. You're not sure that they are Parkinson's disease or not. We have patients who are going up for surgeries like deep brain stimulation, where we would like to put electrodes. And these would only work in patients with Parkinson's disease and not Parkinson plus. So sometimes with multiple system atrophy or PSP, even at the end of 5 years or 6 years, sometimes it's difficult to make a clinical diagnosis. You do have, like you may have some red flags. And so definitely at that time, the only help that comes is from the FDG, and that shows much better than any imaging modality. The images may not show so much of cortical atrophy. Just want to ask a few questions regarding, so how do you, suppose a patient wants to come for FDG PET. So what are the, so what are the things that has to be avoided? Like, because it's a glucose-based scan, I think you have to be careful about the glucose metabolism if they have hyperglycemia. So how relevant would that be, and how well controlled they have to be if there's a diabetic patient?
So imaging of the brain is not affected very much with hyperglycemia because the uptake in brain is very high. But still, we recommend that patients at least fast for 4 hours, and the blood glucose level should be less than 200 milligram per deciliter. And if it is high, we can give insulin to bring it down. But again, you need to wait for some time. So it's better that patient comes with a good glycemic control. And we don't use contrast agent when we are imaging neurodegenerative conditions or for epilepsy in that case. So we don't need the serum creatinine to for the contrast agent. Just good fasting and good oral hydration, so that the clearance and the radiation dose to the body is less.
The other similarly in patients with F-DOPA PET, so patients usually are going for
Yeah.
F-DOPA non-dopaminergic medication. So it's sometimes it's difficult to stop.
Yes. So if patient is on Syndopa, then it is difficult to stop, but it's not much affected in the scan, especially with levodopa, because that is supplementing the dopaminergic deficiency which is already there. So it will not affect the scan much. It's just that if the patient is on antipsychotics sometimes, that can cause decreased uptake in the basal ganglia. And uh, suppose the patient is not having Parkinson's disease and the patient is on a number of medications that can interfere with the F-DOPA uptake in the basal ganglia, then that can be an issue sometimes. But those are very rare, I think. Usually
So,
it's properly screened and referred.
so now that there are two more the scans which are available like TrueDat, which we have here, like the DAT scan which
True
is
that.
available here and the TrueDat is here.
True that can
So
be done with technetium labeled SPECT.
yeah, so is there a difference between the two, or is it more or less? I
Yeah,
mean, the
so
cost.
imaging wise, I would always prefer PET scan because the resolution of SPECT is very low. Uh, PET gives good images, and then TRODAT availability is less. It's quite expensive, as expensive as F-DOPA. So F-DOPA is produced uh, uh, monthly twice in our city. So the patients are pulled up and we do the scan. If it is produced more regularly, then we can do more regularly the scan, and hopefully the costs will come down.
Okay. So because TRODAT for us also to look at the, I'm only talking about the visual picture. F-DOPA gives a very clear,
Yeah.
neat
Crisp
picture.
image.
Yes.
Yeah, always
Yes.
PET gives better resolution images compared to the SPECT and gamma camera images. PET
So
images with the color uptake and all that are visually very appealing, and we can differentiate the normal
very.
versus abnormal areas quite easily compared to that scans.
Yeah.
Is
And
it?
we can, I think, Dr. Mansoor, can we fuse these images with our MRI, right? MRI CD, which is available. We can
Yes, sir. We
always
can we can fuse. There
fuse
are
up.
softwares that fuse post imaging.
That easily can be
So
fused. Brain especially can be
ye-
easily fused with these scans. Even if we don't have PET MR, with PET CT data, we can the PET data of the PET CT can be fused with the MRI data, so that
yeah,
things get
they're not as
quite
good as
easy.
integrated PET-MR imaging, but it's yeah, something is better than without
Yeah, definitely we can fuse.
having
I
at all.
think I have seen quite a number of patients. We have done the fusion here with the software available, so it's really good. The fusion software.
For most of
Yeah,
the immune disease, it's not necessary to have a PET-MR. So I think that works up more when you're planning for maybe a surgery or a epilepsy planning where you need a very precise targeting, I suppose, but
Localization. Yeah.
localization. The
We can
other
read the images side by side. They are quite helpful. We can pick up the atrophy of the midbrain and pons very nicely on if you're just having the MRI scans with us.
So do you? So the most of the times that when we see, we actually prefer only a eyeballing technique or only a visual imaging. Do you think there is a role of, I mean, quantification of the abnormality?
Yes. Yes, the statistical parametric mapping is very important, especially in Alzheimer's, yeah, the dementias. And whenever there is mild cognitive impairment and subtle areas of hypometabolism which can be missed, so the statistical values that we give a good insight, and it helps a lot. But if we are not using them for a long time, then we become more experienced in picking up those subtle changes also. The statistical parametric mapping is very important, and uh, the guidelines also suggest use of statistical information in diagnosing these deep conditions.
So, so the format that you use for, I mean, just the FTOPA and the FDG PET is usually kept uniform for all centers, or you think there are variation in the color coding system? I mean, I'm talking as a very lay neurologist, because we just look at it and then we decide that this is the color, this is the color. So red is bright,
Yeah.
green is low. So I'm just wondering, is it the same color coding which is universal,
Yeah,
or
so that is very variable. It depends, at which window you are appreciating the disease well. So it's variable, it's interdependent, and then it also depends on the printer quality. So when you give the print and you just look at the film, so it is very different. It differs from center to center. So a glossy film is different from a plain film, and then the size of the film that is given. So basically, reviewing the CD on a software, DICOM software, is the best.
so other question that I want to ask is, like, you have patients with movement disorders will have a lot of movement artifacts, or say they have tremors. Will How much do they have to be sedated? Like when you do an MRI, for most of our patients with Parkinson's disease, we usually have to do it under sedation, or is
Yeah.
some movement still okay?
Yeah, so sedation is used when they don't cooperate for the scan. But usually they do. I haven't used sedation in FDOPA scans so far. We've used them in children, in epilepsy, the interictal PET. Yeah, so that is helpful there a lot. We fix the head in a, there is an attachment which doesn't allow that much movement. The scan goes on for like 8 to 10 minutes. So that part is quite taken care of, and we allow one family member to be there inside the scan room when PET scan is going on after the CT scan is over. So that also helps sometimes, and we haven't had the need to give any sedation so far. But if it is required, then just diazepam and something which can anti-anxio anxiety medication can be given rather than anesthesia.
I mean, seriously, it has been a very major help, and I think the onset, has helped us in so many situations where we are in a fix.
Yeah.
So it's a great boon. So do you think in the future we would be imaging other alpha-synuclein or tau, or right now FDG PET does work very well, FDOPA PET is working well because the functional component at least is picked up.
Picked
But
up, yes.
so, I mean, right now
So
the molecular testing is still
yeah,
research.
advances in radiopharmaceuticals is there. It is very fast advancing, and but the only thing is the availability of these radiopharmaceuticals. If it is widely available for clinical purpose, then we can use them. uh, but they're still limited to research work, and more
Yeah, I think that's
the elite institutes do it a lot rather than the hospitals and the commonplace.
true, because I don't think they really are not adding so much of a value currently. I guess it's just to uh, just give us a more clue towards a pathophysiology rather than actually changing the
Yeah.
therapy modality right now.
Yeah, something related to algebras, right? There are new nuclear
Amyloid imaging, and
amyloid
you
imaging.
can label various proteins, and they go and bind to those receptors to the cells, and there is dopamine 2 receptor imaging, and then there is opioid imaging, and so many things are there. It's huge, actually.
Anything is very useful, like out of all these pharmaceuticals, like maybe specificity for Alzheimer's might be increased, right? One or
The
two of
most
these.
important, yeah. So here, it helps a lot in drug development, basically. So if the trial, there is a drug that can reverse the amyloid deposition in the brain. So that is where the amyloid imaging will be most helpful.
Anything is available, Dr. Rukmini, in that area? Alzheimer's, any drug? No.
Yeah, I think that's what actually he already mentioned the available amyloid imaging parameters. Right now, there is a chance that you can get a monoclonal. I mean, there is a monoclonal antibody which is being used for patients with early Alzheimer's. But if something comes up for maybe an MCI phenotype, but that also can be picked up on FDG PET. But maybe if they want it very early, maybe then the amyloid imaging would be required.
So after the diagnosis, like how it is going to change the management, like if you diagnose between Parkinson versus Parkinson plus or other disorders.
It makes a lot of change because the Parkinson's disease patients, we give a lot of, dopa agonists. The medications which are useful for Parkinson's disease and Parkinson plus are similar in certain ways. So levodopa carbidopa is useful for all, but the remaining medicines which are there, like MAB inhibitors or dopamine agonists, they all work more for Parkinson's disease, and they can cause more complications in the Parkinson plus syndrome. Like they can worsen the autonomic dysfunction, orthostatic hypotension in MSA, or they can cause more confusion in PSP. The advanced therapies which are available, like apomorphine or DBS and all that, is useful only in Parkinson's disease. So it makes sense to check it out. Even in young patients with young onset PD, sometimes you have a dopa responsive dystonia versus a young onset PD, and that can be picked up very well by the fluorodopa PET, because dopa responsive dystonia also responds to levodopa. It looks like young onset PD, but it doesn't have the dopaminergic denervation. So whereas PD will have dopaminergic denervation. So again, the treatment options will change with them.
Okay. Yeah, thank you, Dr. Mansoor. Thank you, Dr. Rukmini. Very active discussion over this topic. A very important topic, of course. Like many people don't know about the new role of nuclear imaging, especially in the case of movement disorders and dementias. Basically, we always think that MRI is the final thing, and MRI we are sometimes definitely not able to come to a definite conclusion whether it is really PSP or MSA or real Parkinson's. It's very difficult until it is very later in the stage of the disease, like to pick up that heart cross burn sign and that hummingbird sign. These signs to develop, I think it takes very long course for this, and I think our molecular imaging definitely picks these things very early on, and it really guides the treatment. So thank you, Dr. Mansoor. Thank you, Rukmini, for sparing your valuable time. Actually, you are really busy in with your patients, but yeah, thank you so much. Thank you.
Thank you for inviting.